welcome everyone. I'm Dave Forsch from New York. I'd like to welcome you all to the AO Trauma Fellows webinar series. This evening's session is going to be on distal humerus fractures, to osteotomize or not. That's going to be the question that we'll be talking about this evening. So again, I'm Dave Forsch. I am an orthopedic trauma surgeon at Mount Sinai in New York City, and have the pleasure of moderating alongside two of my friends and colleagues, Dr. Diane Nam, who's from University of Toronto at Sunnybrook, and Dr. Milton Little, who is out west in Los Angeles, California at Cedars-Sinai. So just some housekeeping. AO North America is an independent nonprofit surgical specialty society that's dedicated to improving the care of patients with musculoskeletal injuries. The AO does not endorse nor promote the use of any product or service of commercial entities. So, overview. In this webinar, we're going to discuss the assessment, preoperative planning, and clinical decision-making, and some of the technical considerations for the management of distal humerus fractures. And by the end of the session, you should be able to recognize and assess relevant pathoanatomy of distal humerus fractures, also discussing and understanding different surgical approaches about the distal humerus, and lastly, probably more importantly, understand when and when not to utilize an olecranon osteotomy for the management of these injuries. So here's our agenda that we're going to try and stick to. We'll move to Dr. Nam's short talk about who needs an osteotomy anyway, followed by Dr. Little, who will introduce us to some alternative approaches to consider. And then we'll do a short literature review and get into the crux of the hour with some interesting cases that we'll close with. Again, feel free to use the Q&A session. And with that, I'll turn it over to Diane.
Thanks, Milton. Oh, sorry, thanks, Dave. Let me just see. Well, it's great to have everyone here tonight. My task has been to really talk about whether an osteotomy is always needed. I think it's something that we consider every time we do a distal humerus fracture. Let's just have a quick look at these x-rays. So there are 5 cases here that we're going to review, and think about which of them that you would choose to do an osteotomy. I'm going to just quickly go over some of the exposures that offer good visualization without an osteotomy, as well as how to avoid complications in the posterior approach to the elbow when you're doing a distal humerus fracture. Our first case is a young woman. Many of you have come across this type of an injury. Standard fall, healthy, isolated injury. And these were her radiographs. So you can see that of all the options, the first thing running through your head is probably, this is one that's probably amenable to avoiding an osteotomy. It's hard. You can see an intra-articular split, and there is some mild comminution, but really you can see the columns really reasonably well. So what I did was did a triceps-sparing approach, a paratricipital, and a one on either side. You can see that with a reduction film and looking at the CT, that was what my first feeling was, and the CT kind of confirmed it. It always looks worse, as you know, when we get a CT, and you can see that there is some concern in the middle of the joint, but I think, for the most part, if you can get the columns together, maybe the joint will be reasonable. So our approach for this one was to really consider how to do this. And I always try to make the effort of sparing the triceps whenever I can. So this is what was done. And orthogonal plating is always very standard. I kind of consider not just particular plates, but plates in general to do the job. I put plates where the reduction is required, if it's a buttress, or if it's needed, because the fracture fragments vary in each case. What about a second case? This is an older patient, a farming type injury, a little bit more higher in comorbidities, but also closed. Have a quick look at these films. So you can see that there's a bit more comminution of the metaphyseal region. Maybe there's more comminution in the joint as well. But again, if I were to think about the complexity of this injury, I'm thinking, okay, again, I think I could try to spare my triceps here and avoid an osteotomy. However, I do need to see the reduction. I need to see the joint and make sure that that's very reasonable. And because it's in the middle of the joint, just over the trochlea, I might have some challenges. But if you look carefully at this X-ray, you can see that the fracture line of the intercondylar split is on the lateral side of the olecranon, and that's kind of my hint, thinking that I might be able to get away with a triceps on approach. This was the CT, and you can see always a little bit worse, more comminution. But again, larger fragments that I felt was amenable to a triceps-sparing. So this is what was done. And again, reconstruction of the joint, orthogonal plating, plates were needed, the same kind of principles. And I did this through a triceps on approach as well, and was able to get it together. Third case, higher speed now, 38-year-old motorcycle, motor vehicle collision actually, and this one is open. This is, kind of a standard type of injury, especially in level 1 trauma centers. And I think all of you will probably have come across some of these types. The concern that you have when you have an open injury, especially high speed, is bone loss. And bone loss in the distal humerus is quite challenging because it's involving the articular segment oftentimes, or close to the articular surface. Trying to graft these is a little bit difficult. So have a look at these films, and you can see that the joint's really shattered, but you can see associated fractures with this injury. One of the things that you're always looking for in association with the distal humerus fracture is whether the radial head is dislocated, if the olecranon is a separate fracture, what are the actual fracture lines? You can notice here that the ulna is fractured in the proximal portion, but also the olecranon is off. And when the olecranon is off, it's now your opportunity actually to consider working through the fracture. You can see the gas in the joint, indicative of the open injury. A lot of comminution, the radial head is out. And then you can also see now coming into view that the olecranon actually is there, and we do have our self-made osteotomy. So while I try to avoid an osteotomy, sometimes the patient affords me that opportunity, and it's a great chance to use the fracture. So using the fracture, you can see that the reconstruction here was to work really through the fracture and then fix the ulna at the end. Again, multiple plates, even wires are very, very helpful, fully threaded K-wires to really get joint segments together and stacking to reconstruct that joint injury. Our case 4 is another high-speed motorcycle crash. And you can see this injury is a little bit more concerning than what I would stretch indications for triceps on approach. A lot of comminution here as well. But if you look at the CT scan, it looks like there are larger fragments on either side. Sometimes when you're trying to rebuild the joint, it's much more difficult to actually see the central portion on a triceps-sparing approach. And oftentimes you can misread it. And if you cannot restore the width of the joint, it's very hard to actually get a congruent elbow. So these are things that you must consider, especially if you're going through your mind as to what you're going to choose. But again, a triceps splitting approach here actually gives you a very good view of the intercondylar region. And you can see this one was done by reconstructing the joint similarly for a triceps split. And again, reconstructing the columns. And at 6 weeks, even though there was significant comminution, you can see a lot of the bone coming down, heterotopic bone overlying the plates and in the fossa, but still came together and started moving the patient really early. Our last case now, you might think she's going to need an osteotomy on this one. Okay, so 59-year-old nurse fall on the ice. You can see this very classic capitellar trochlear shear injury. And again, how are you supposed to get to the front of the joint through a back approach if you actually don't do an osteotomy? Well, the nice thing about these types of injuries is that in addition to triceps sparing approaches, you can actually just do a column approach. And a lot of times on these ones, you can expose the lateral side without violating the collateral ligaments or the extensor origin. You can actually nicely visualize the front of the joint and the back of the joint. So this one was done through a column approach on the lateral side where the majority of the injury was. You can see this is on the ulnar side, large trochlear fragment shearing right off. And you can see now the lateral side coming into view with that capitellar fragment. However, doing a lateral column approach really affords you a lot of assistance here. You can see you're able to still get posterolateral to get a back front capture of the capitellum, as well as doing a separate window to get the trochlear component back and attach it back to the medial column. These column approaches are very helpful. It preserves the collaterals. You get good front and back view. And it's basically, if you see the red lines there, you're taking off brachioradialis in line with more of a direct lateral approach distal to the elbow. And basically, you're just unzipping that lateral side, seeing it front and back, elevating the triceps off the back, seeing, and you can actually visualize both to the limits of the coronoid and olecranon fossa. The paraolecranon approach may not be familiar to everybody, but basically you're just making a triceps split, but just a little bit more lateral to the olecranon. And it's very nice because you have majority of the triceps on, but you actually get a closer view of the joint space, and you get an actual very good view of the lateral trochlea and the entire capitellum. When you actually open up the fracture itself, you can actually sublux or lift up on the olecranon with a towel clip. Oftentimes you can get good visualization of the olecranon fossa. You can see that it's very helpful in those fractures where the fracture exits just lateral to the olecranon, and you can definitely get that together with a very simple closure. The tricep split is probably going to be your best approach. You're not doing any osteotomy, you're not having to fix anything at the end of the case, but you can see right into the joint. Oftentimes it can be facilitated by a little tip excision of the olecranon tip if you want a little extra view, or even getting a little bit more hyperflexion in your elbow to get to the distal and anterior parts. Mind you, you do have to have some transosseous fixation to actually repair the triceps back on. But again, think of it as a zipper that you're unzipping, getting into the joint, and then you quickly zip it back up. So again, nothing to fix and nothing to plate. So really the tips on sparing the triceps and not having to do an osteotomy is really optimizing on your soft tissue approaches, and little things like excising the tip of the olecranon, even using the olecranon fossa as a reed is very helpful. The intact olecranon itself is an excellent gauge to read as well, because sometimes the joint can be quite smashed on the distal radius, on the distal humerus, and having it reduced back to the olecranon is a very helpful gauge on the congruence. And then, as I mentioned, hyperflexion of the elbow is very helpful if you have to get a little bit more distal into the front. So if you look at all the cases that we've reviewed, basically all of them can be done without an osteotomy, from your very simple to the most complex. So please keep in mind as take home, the tricep split paraolecranon approaches are something that you should have some familiarity with. They're very good to have in your back pocket, especially if you're thinking that this is something that you can do without an osteotomy. And whenever possible, always use a fracture as your surgical approach. Hand it over now to Milton.
That's great. I still think the one where you use the olecranon is cheating. But all right, let's get this going. I am going to take over the share. All right. Can everyone see? All right. So hopefully at the end of this, we'll be able to understand when an olecranon osteotomy may be beneficial, to understand some olecranon osteotomy techniques, as well as understand some options for osteotomy fixation. And then lastly, learn additional alternatives to an olecranon osteotomy, where you still may get additional visualization without needing to depend on an osteotomy. So for me, when do I perform an osteotomy? So if there's articular comminution, if there's a midline articular split, or more medial or trochlear sided articular split where my osteotomy is not going to provide adequate visualization, if there's a separate trochlear fracture, or if there's some kind of trochlear impaction, because those are the ones where often getting your read in terms of your length may be a little bit difficult. And then when you're struggling in visual and you can't really visualize what you need to see, right? So I'll often give myself some time if a case looks amenable to osteotomy. But if I start to see myself struggling, or if I find myself unable to get adequate reduction or visualization, then I'll move forward with an osteotomy. And that can be anywhere from 5 to 10 minutes, just depending on kind of what we're seeing and how things are moving forward with the case. And so what are some reasons not to perform an osteotomy? So there can be some complications associated with it, one of which is the risk of non-union or delayed union, and that can be present in anywhere between 0 and 7% of patients. Additionally, if there's a situation where you may be thinking about a patient who may need an arthroplasty in the future, or if there's so much comminution in their age, puts them in kind of the age group for possibly best being treated with an arthroplasty, then avoiding an osteotomy in those patients may be beneficial. And then, sometimes people complain about the additional time that comes with it. And so, there's nothing more kind of a reminder of the additional time is, when you finish a 6-hour or 5-hour or however long it takes you to do a distal humerus, and then at the end, you have to put together the osteotomy. So just knowing there's some extra time that goes into afterwards. And then about anywhere between 0 and 15% of people will complain about their implants. And so the need for possible implant removal in terms of osteotomies are something to think about. So this is our patient. So this is a 38-year-old man who fell from a ladder and also presenting with kind of an open distal humerus fracture. Things that stand out for me are there looks like a lot of impaction. And then when you start to look at the spool, you can see that there's a lot of comminution in that region. And so when we look at our 3D CT scan, you can see kind of how many small articular pieces there are. So for me, this is kind of a this is a no-brainer for me. So he has all of the components, kind of mid-spool comminution. He has trochlear impaction. And, I think that for this, it's going to be very difficult to see that comminution without the osteotomy. And so how do I perform an osteotomy? Right. So the goal is to kind of find that bare area in the trochlea. And you can imagine if your osteotomy is too distal, or too proximal, as in these red lines, it really can alter your visualization. So, for me, I often will localize where I want to do the osteotomy. And since I'm doing a chevron cut, I'm going to go ahead and place a K-wire right at the midpoint, and then confirm that on radiograph. So I know that's going to be the midpoint of my osteotomy. And there you can see the bare area, which we refer to, where there's no articular cartilage, where we want to avoid, we want to be in that region rather than being in a region of articular cartilage that's going to impact or cause the risk of arthritis or other problems with it. And so I'm doing a chevron osteotomy. I'll usually place a Curlex or a lap in between the distal segment or in between the distal humerus and the olecranon, and I'll use my saw in order to cut the region, and then I'll use an osteotomy to finish it off. And so one thing to think about, for some people, they feel that it's a lot easier to place a screw or place some hardware in position prior to doing the osteotomy. For me, just because of the risk of the kerf of the blade and some bone loss, I usually will not pre-drill. And so it doesn't really affect me in the end post-operatively, but it's just something to think about when you're performing osteotomy. And then there you can see an osteotomy post-fixation with great positioning in that bare area. So, right, so when we're thinking about the osteotomy, so this is our patient, this allows us to get all the fixation we need for this patient. And it allows us to kind of get our hardware in place. It allows us to get a great visualization of the articular segment. And you're not going to get that without the olecranon out of the way, especially in those areas in the middle where you have the highest levels of impaction and the really small pieces, which you're going to have to restore. And so how do I fix them? So there's many ways. So tension band wiring is one way. Pre-contoured plates can be utilized. Intramedullary screw with tension bands may be the fixation of choice for some. And then for me, I lean towards mini fragment fixation for one of those reasons we mentioned before, i.e. that risk or the concern with hardware irritation. And so here's our patient. We did not pre-drill. So, using a point of reduction clamp to get my reduction, followed by placement of a wire to tension off of. And then here's my mini fragment plate, which has been tensioned with an intramedullary screw for increasing, for decreasing the risk of displacement of that fragment. And so here's the patient's immediate post-ops. And then 2 years post-op with no signs of kind of arthritis, but the patient ended up undergoing hardware removal, ulnar nerve decompression for some pain and stiffness. And so let's get to another case. So this was a 23-year-old, so status post MVC. He had a preoperative radial nerve palsy. These are our preoperative imaging. You can see how great our preoperative imaging is. So we actually got a pre-op CT scan. And so for him, this patient doesn't have a lot of comminution, but there is a little bit of impaction along the trochlear side and a little bit of impaction along the radial side. So thinking about that, what are other ways in which we may need to get additional visualization? And so here you can see that impaction or that separate fragment along the radial side. And so what about situations where I want to try to avoid an osteotomy for me? So this is described in 2006. And so this is the anconeus flap or transolecranon approach to the distal humerus. And so this allows you to improve your visualization along the radial aspect of your articular segment. And so what we're doing is actually elevating the anconeus muscle on a pedicle and opening up the capsule around the region, which gives you great visualization of not only the distal humerus, but also the radial head. So here's a cadaver where I utilized kind of that approach. So there you can see the anconeus held by the pair of tweezers. There you can see where we've elevated the anconeus and kept the fascia intact posteriorly. And then you can also see proximally where you have capsule intact. And as we start to remove the capsule, there you can see the exposure you're getting of the radial aspect of your distal humerus as well as the radial head. So it allows for visualization of both. It's important here you can see post hardware placement with the anconeus replaced right in the middle. And so for us, same thing, we performed that anconeus elevation, which allowed us to get great visualization of the articular segment. There we placed our provisional K-wires before placing our bigger clamp and advancing those for fixation. And then once we did that, we were able to fix our radial side, followed by placement of our posterior lateral plate, and then placement of a medial plate for fixation. And there following, we did not have to perform our any osteotomy for this fixation. And there you can see kind of final radiographs. And here's our final follow-up at 8 months. And so there are limitations, right? So it does not really improve your medial visualization. So if you have a medial-sided split or medial-sided comminution, it may not preclude you from, it may not allow you to get improved visualization. But the good news is it doesn't preclude you from an osteotomy. So once you elevate the anconeus, you can still perform an osteotomy if necessary. So here's another case, and I know I'm supposed to talk about osteotomies, but here's a 56-year-old woman kind of with a split. There you can see it's more along the trochlear side. She does have some impaction along the radial side. There you can see her CT cuts and then our 3D cuts showing that same impaction and the anterior aspect of the injury. And so for us, we were able to maintain her olecranon. We were able to get improved fixation here with both a posterior lateral plate and a medial plate. There you can see final fixation with reduction of our articular injury and avoiding an osteotomy for this case. And then this is the last one. So this was a type 1 open distal humerus. And there you can see a little bit more comminution and impaction, both on the trochlear side as well as on the radial side. Here you can see the traction view, which shows how much that impaction is present along that radial side. And so for us, looking at this injury and with the impaction in place, I felt like I would be able to get better fixation and better visualization, especially given where the location of that split was. So we did perform an osteotomy, and there you can see our wire in place, marking the position of the osteotomy. There you can see us with our wires now in position and advancing. You can see a provisional plate used for fixation of that medial side. And then there you can see us kind of moving forward with placement of our posterior lateral plate. And then finally with placement and confirmation of our positioning on our lateral views, followed by placement of our medial plate and articular screws in order to generate compression across that articular surface. And then lastly, fixation of our osteotomy with this mini fragment plate. And so these are our immediate follow-up films. And then these are our final follow-up films. So we'll skip ahead for these next two cases and get back to them, but we'll get to our take-home points. And we can actually move on. And so we can, our big take-homes from this are going to be, our osteotomy is going to allow us to get adequate visualization. I think for you, you want to think about the ways in which you are going to generate or get appropriate visualization. And if you're feeling like you cannot see anything, move forward with the osteotomy. Have a low threshold for it. The additional time is okay, because that's going to allow you to appropriately manage the patient. Think about those situations where you do need radial-sided visualization, because then you'll be able to do that with the use of the anconeus flap. And once again, that does not preclude your osteotomy. And then for me, both osteotomies as well as the anconeus flap do not impact my range of motion precautions post-surgically. I'll allow a patient to move immediately. And so we start working on range of motion unless there's some soft tissue region which precludes early range of motion. And so with that, I'll get it back to Dave Forsch and we can go from there.
All right, so really, really good content there, guys. And we will move on to a quick literature review, and then we'll get into some cases, because I actually had some questions myself for both of you that I think would be good for the audience. And again, to the participants, I would encourage you to utilize the Q&A. All right. Okay. You guys can see my screen? Yes?
Yep, we can see it.
All right. So I think it's always kind of apropos during these webinars just to introduce you to some of the literature that I would invite you guys to familiarize yourself with as it relates to the topic that we're discussing. So the first paper here is a cohort out of China where they looked at 67 cases retrospectively. And they looked at patients that were over the age of 60 in their cohort that they found had a more significant loss and extension after a triceps-sparing approach. And of those patients that were over age 60, 37.5% of them actually had only good to excellent male elbow performance scores, as opposed to the younger patients, certainly those who were less than 40, that all had 100% as far as their functional outcome scores. So what they concluded out of this cohort was that patients that are older than age 60, an olecranon osteotomy may be a better choice. In patients that are younger than 60, significantly those, or particularly those who are under the age of 40, either approach would confer a satisfactory outcome. And looking at another paper out of Asia that it just happened to have 67 patients as well. I thought that was pretty interesting. 31 of which had a triceps-sparing approach. What they noted was that the cohort that had the triceps-sparing had decreased EBL, decreased complications and procedure time, and similar for C1, 2s, and 3s, functional outcome scores, looking at the MEPS. And so what they concluded from their study was that there were better functional outcomes for type C1, C2 distal humeri that were exposed with a triceps-sparing rather than an osteotomy. Even for the more complex C3 fractures, they noted similar recovery in elbow function, which was achieved with either approach. So obviously when you have conflicting information, you have multiple studies, and it's hard to hang your hat on one, it's nice to look at a systematic review and a meta-analysis. So this was one that was published in 2021, looking at 9 studies, which collated 637 patients. And overall, they found no significant differences in excellent to good function, looking at the Mayo elbow performance scores, duration of operation, complications, and EBL. So they concluded out of the meta-analysis was that an osteotomy didn't yield additional benefit on the incidence of excellent or good elbow function. But looking at sensitivity analysis, they found an osteotomy might be associated with longer duration, greater EBL, and a higher incidence of complications. So Milton introduced you to an Anconeus pedicle. There is some literature looking at this, whereby, so this is a study out of Turkey looking at 44 patients with a mean age of 35, 18 of which had an osteotomy, 22 had an Anconeus pedicle. And what they found in the trap approach was that there was a higher arc of motion of 108 versus an osteotomy that had only 98. There was no difference in outcome scores. And the complication rate was 27.2% in the trap group, as opposed to 55% in the osteotomy group. And what they concluded there was that a trap approach is a successful approach in the treatment of intra-articular distal humeri and provides better arc of motion in comparison to the osteotomy with reduced complication and reoperation rate. So again, a lot of literature out there, but something that you should at least familiarize yourself with. I'd invite you to read those 4 papers. So let's see, we have a couple of Q&As already. So Milton and D, there's a question. How do you preserve the Anconeus muscle when you're doing an osteotomy?
Yeah. So when you do your dissection, if you go back to the, when you're doing your dissection, you're keeping the Anconeus attached kind of to the triceps proximally. And so you've already elevated it up. So it's already off of the olecranon at that point. So the main thing is just avoiding any kind of trauma to it. Oftentimes I'll put a little, you know, the ones that I've done, I've put a lap on it that's, you know, moist to keep it nice and moist during the surgery, avoiding any kind of trauma to it. And, you know, for me, I've the first time I saw one kind of in person was actually in a lab with Andy Chu, who's a huge component of it. And he does it for most of his, all of his distal humeri. And I think, you know, it's really, you're able to kind of be careful when you do your dissection along that radial side, then that protects it. You know, I find it distally, you elevate it, you keep the fascia on it, and then that allows you to protect it as much as possible.
Yeah. All right.
And I'm not doing, so there's a question from Nate Schaefer asking about the kind of hemi peel with it. I'm not doing a hemi peel with it. I'm keeping the triceps completely attached to the, you know, completely attached to the olecranon, so that I'm not injuring, or I'm not taking down the extensor mechanism at all from that standpoint.
All right, so let's get into a few cases, and then we'll come back to some of the questions. All right, so this was a 58-year-old gentleman had a drunken incident where he laid his motorcycle down and had this distal humerus fracture. So we'll take a look here as the CT goes. And Diane, what I'll show you what we did. We have about 8 cases to get through, so we'll gauge time. But again, feel free to ask any questions, and we'll kind of get to them towards the end. But Diane, as you look at this, any thoughts about what your approach is going to be? Is this going to be a 2-hour distal humerus without an osteotomy, or is this going to be a little bit of a longer afternoon for you? Or how do you think we should address this?
Yeah, so Dave, I am going to probably be there longer than somebody who does the osteotomy, but you know, you balance the time that you do the fixation for your osteotomy versus keeping it on and kind of plowing through with a soft tissue exposure. And for this one, I'm looking at the intercondylar or the articular injury, and I think this is something that it's probably going to be able to be read indirectly. Now, it is in that terrible spot right underneath the olecranon where visualization is the worst when you're keeping the olecranon on. However, a lot of these articular fragments are attached to the cortical bone in the fossa. And if that's the case, you can actually read it indirectly, reduce it to the fossa, and you will have the joint reduced, because you can really gauge nicely the rotation of that fragment as well. You know, in the trochlear section, it's a big spool. So that rotation, if it's separate from the olecranon cortical bone, it's a much more difficult read. So I may be going more towards a triceps split, or, you know, a more aggressive type of approach. Here, I still would hold off. I'm in the position of not doing an osteotomy. I think this is one that I could probably do through a triceps split, and working through getting that indirect reduction and getting that joint back together.
So all good points. So it's like we know each other, Diane. So that's
I think the other thing I was going to say, Dave,
yeah,
is, you know, I think that when people think about a paratricipital, right, you're going to do your dissection. If you do your dissection along the medial and lateral, on the radial and ulnar side, as if you're going to do an osteotomy every time, that gives you a lot more flexibility and visualization, right? So, you know, as you take your dissection distal, you really can see a lot more, and you can manipulate the fragments a little bit better without kind of destabilizing, you know, the collaterals, but still being able to do some things. And even though your direct reduction may be blocked.
yeah. So with this one, for me, this is not an osteotomy case. Milton, you bring up a good point. If you're doing your surgical dissection in preparation for potential osteotomy, then you don't really burn any bridges. And for some of these, you can sublux along the ulnohumeral articulation and still visualize some of those fracture patterns that are more medially oriented. When it's kind of due center of the trochlea, you can have a difficult time visualizing it. But with just some gentle subluxation and dissection, you still, I think, can see some of these more ulnarly or medially based splits along the trochlear articulation. So that's what we were able to do here, get it clamped, get it lagged, a column screw up the medial and lateral columns. And then, I'm a fan of orthogonal plating as well. I also do use parallel plating. I know some people kind of really fall strongly into one camp, but I think whatever the fracture dictates is whatever the fracture needs. So this was one that we were able to fix without doing an osteotomy with orthogonal plating. So this is, I think you showed this one, Milton, right? This was the 56-year-old lady, had a ground level fall, and you can see the 3D recons here. And so, I mean, Milton, you kind of talked about this a little bit, but anything outstanding here that would, be a consideration for you when you're thinking about approach?
I think it's the one thing that you see is kind of the same thing you saw with your injury, right? So if you look along, even though there's a split in the trochlear region, it's almost all the way ulnar, right? So, you're likely going to be getting your visualization of that, that trochlear sided split on the ulnar side by subluxating everything out so that you can visualize it, clamp it. Then you're going to lock it in, and then you're going to be attaching things to the spool proximally. So that was, I think that's how I went about this one.
Yep. So Dr. Little was able to do this one without the osteotomy, get the articular segment reduced, compressed, and orthogonally plated. So here's another one, open distal humerus fracture, a lot of comminution. So traction views, we haven't really talked about this. Are you guys always getting traction views on every distal humerus? A CT scan on every distal humerus fracture? Diane, any thoughts on that?
Well, the CT scan for sure. I think, 2D reformats of the CTs even helpful, but the 3D recons have really changed how we look at our complex articular fractures. So for me, a traction view is not as necessary. I think it's nicely done when the team reduces it and puts it in a splint. And that's what you're aiming for, to just take the tension off the soft tissues, which is actually more important than actually getting this view. But for me, the money is on the CT.
Yeah.
Yeah, the 3Ds are so nice nowadays that you can kind of see everything. I try to think of it like, the one thing that you can see that you don't see sometimes on the 3Ds are the areas of impaction, right? So the 3Ds can sometimes gloss over with the reformatting. They can gloss over extra fragments. So really looking at the 2D imaging helps me see all the real details.
Yeah.
I mean, if you think about it, the X-rays and the 2Ds are really for us to visualize a 3D image in our heads, right?
Exactly.
And the 3D recon just give it to you. And I think it's really helpful. And it's not a big deal at most centers anymore. So something to
Yeah.
always consider.
Yeah, I think most people have the capacity to do the 3Ds. So a lot of comminution here, central within the trochlea, and to the points that Milton introduced you to. So Milton, you mentioned that when you go automatically to an osteotomy, so was your mind made up that you were going to do an osteotomy with this case
No, if you go back,
right away?
so right, if you go back to the pictures, right, you can see the one that has the wire in. You can already see those wires both on the medial and the radial on their side. So I probably gave myself a little bit of time, and I was like, you know what? I think these little pieces of impaction are probably fooling me. And so I went to an osteotomy next. And you can even see, right, you can see the little line there that shows where I have my lap in position.
Yep.
Getting ready to do my cut. So making sure I'm happy with that.
Yeah. All right. So nicely done there. And immediate post-op. So you mentioned you allow them to range immediately. Diane, are you any different? You letting them move right away?
Yeah, so all my distal humeri basically are in a soft dressing. Remember, the collaterals are usually intact. I let them range immediately, active assisted. Usually I splint them overnight in extension as the intercapsular volume is the smallest, so less swelling. And I take them out of the splint in the morning and they start moving ASAP.
Yeah. The one thing I will do is I'll have our OT team make a orthoplast splint, an extension night splint. So, they'll take that home with them. You wear it at night, but during the day, take it off, start moving. So I usually make that day 0 or day 1, depending on if they're going home or if they're staying overnight. And I usually don't make them wear it for longer than 2 weeks. But I don't want them to lose that terminal extension. And most of them, the flexion they get back, but the terminal extension, once they lose it, it's that part's hard to get back.
Yeah, the extension splinting. I was going to say that the extension splinting is super helpful. I generally will allow them to move right away. Unless I'm really concerned about a tenuous reconstruction, but for the most part, if I get compressive, articular, and columnar fixation, then I'm allowing them to bend right away. Diane, you were
I just want to bring everybody's attention to how the osteotomy was stabilized. Oftentimes you see a pre-contoured olecranon plate. The footprint is quite big. It's about 1 centimeter. The triceps footprint is, about that and a bit. Like it can range from 1.5 to 2. And if you put a big plate on that footprint, you're elevating all of that triceps. So I find that the smaller implants, if you do it without violating principles, getting great compression. This is a mini frag plate to lower the contour and not only of the prominence. Oftentimes these posterior plates do have to come out, but think about the triceps really and the footprint that you're leaving. Look at how far it has to go over the olecranon in majority of those cases, and that's triceps. And you're not sitting on it anymore because you're down on bone that plate. So the triceps has been elevated. So think about the damage to the triceps.
Yeah. And it's not, I make a little split just so I can kind of get it over, but I don't elevate the whole thing. So it sits in that split and then it's sitting over the kind of the remainder of it. And then I repair that little split afterwards. I think one of the other questions someone mentioned kind of the same thing we discussed, drilling beforehand or drilling after. I think both are reasonable. The one thing to think about is just being very precise with your saw so that you don't cause any bone to lose in terms of kind of the kerf of the drill of the saw, because if you pre-drill, sometimes that can add in a little bit of a step off or some compression of the olecranon.
All right, so I was just trying to type in an answer. All right, so this is a 41-year-old jumper and had an open distal humerus fracture. We'll try and pick up the pace to get through some of the rest. A lot of metaphyseal comminution here. and I'll kind of skip to the 3D. No coronal elements on the sagittal, but a lot of metaphyseal and paralechonon fossa comminution there. And so for me, what we did with this patient, he ended up getting an osteotomy, even though the articular component wasn't really like right in the middle of the trochlea, but it was almost kind of central of the distal humerus with a lot of comminution and bone loss just adjacent to the olecranon fossa. And certainly because of that, for me, that gets an open or an osteotomy. So once we flip him up, it literally was like the bottom of a Doritos bag of chips. So a lot of bone loss and things just kind of start falling out. So that's never a fun day. And that's what that looks like. You know, the other issue is that when you have these osteoarticular fragments that are lost, you know, you want to make sure that you don't, the tendency is that you want to compress and squeeze that together. And it just kind of sucks. But to Diane's point earlier, you have to maintain that condylar width, particularly at the ulnohumeral articulation. So as much as you kind of want to squeeze things back together, you just can't do that because then you're going to affect their range of motion there. So after grafting of the defect, this is what the final construct looks like. And he actually healed pretty generously and needed an osteoplasty because he had so much heterotopic ossification that had formed. So moving into some of the more elderly distal humeri fractures, because they tend to behave a little bit differently and can be a more frustrating case. So this was a 70-year-old who was power walking in the mall, fell, and had this distal humerus fracture. So you can see very low concerns about bone stock and whether or not you're going to be able to obtain and maintain fixation with this. So in this particular case, we elected to not do an osteotomy, and we were able to sneak around and do a paralechonon approach and get an adequate reduction and some fragment specific fixation with the mini fragment plate there. Again, orthogonal plating, and we were able to obtain and maintain compressive fixation with her, and she ended up doing well. This is another even more elderly individual that Dr. Little treated.
Dave,
So,
just one thing that I was going to say, you know, and I have a low threshold towards, you know, taking that lateral plate a little bit more distal in those geriatric patients, so that I can get some longer screws across it if I need to. Just because, you know, some of the lateral sided plates may not go as distal as you can do with your own, right? If you bend and contour your own plate.
Yep, no, for sure. Excellent point. So this is another 81-year-old ground level fall, low comminution. Milton, any thoughts that were running through your mind about how to approach this 80-year-old?
You know, the same thing, right? It's going to be bad bone. Am I going to need to augment the, you know, our pre-contoured plates with other things? You know, I think this was one where I felt like, even though it was low, even though there's that impaction, once again, I'm looking at where my split is and it's on my radial side, right? So I think that I can see enough and I can get enough visualization of that. And then what am I going to use as my, you know, markers? And one thing that we have is a really good kind of medial sided column, like posterior medial column, where I could put those back together, or that'll be a pedestal to build upon.
Yeah.
I agree,
Right.
Milton. I actually look at the columns when I start to decide on approaches too, because having the columns rebuilt, it really helps you gauge what's in the middle.
Yep.
And so, you know, having those columns, if the columns are smashed, it's much more challenging. But if you can get stability with the columns, if they read nicely, I think it's something that you can really push the indications without having to take the olecranon off.
Yeah.
So I actually have a question for you both. So I haven't done the Anconeus pedicle, Milt. but it seems like you would get the same exposure as you could with a columnar approach. Dan, would you agree with that?
Yeah, so I find that with that Anconeus approach is that it is still a little bit limited. I think when
Yeah.
I've done the column approach, you can go proximal to distal. And really, as Milton mentioned, your limit is not violating the annular ligament, but because you're in front of the LCL. But you know, you can really actually fillet it front to back. As I said, you can actually get to the medial side, just putting in a blunt Holman. You can
Yep.
definitely get to the olecranon fossa. So it really helps to see the entire joint. So I haven't actually done the Anconeus. I prefer the column.
The other
Yeah,
thing with the
same. So
column is that,
huh?
oh, sorry. The other thing with the column is when you have that separate avulsion fracture of your kind of your LUCL attachment, that's a big win because you can pop that out. You can
Yeah.
kind of really get better visualization across the front. It gives you a lot more ability to subluxate the joint and kind of get your fixation and then plan on bringing that piece back in to provide your stability for it.
Yeah. Yeah. So I've used the columnar approach, you know, more frequently, and I may give the pedicle a try, just to see how it feels in my hands. So I think we have two more. This is another octogenarian. So traction view, even here you can appreciate the split, the distal fracture, and some of the impaction that's there. And I'll just jump right to the 3D movie. So again, this has all of the you know, challenges pathoanatomically that Milton brought up. So there's comminution there, there's the anterior impaction, and then there's a split as well as a coronal element to the capitellum. So for me, this one automatically gets an osteotomy. I'm not as good as Diane. So the microsagittal saw and fragment specific fixation for this one with some, so Diane introduced, I think, a case where using the lost K-wire technique can be useful. So where you have these really small osteoarticular fragments, you can leave the K-wire in place and then just snip it and pack it into position with some mini fragment fixation as well for this patient. So this was kind of the entire bag for this patient, and this was her final alignment and reduction, and she actually went on to do very well and maintain her fixation. Last case, not so old. This was a case of Milton's, a 63-year-old that had another fall, similar articular impaction. You know, you guys kind of get some of the recurrent themes here. A little bit of a coronal element as well.
And I think for her, the big thing was, you know, sticking to what Diane mentioned earlier. If you go back and you see all of those, you know, impacted pieces across the front, I am going to be hyperflexing after I do my osteotomy so I can visualize those and get that reduction of those pieces. You know, so that was definitely necessary for her. And there you can see that lateral plate, like I talked about earlier, that gets me a little bit more distal fixation. It also fixes that little avulsion fracture along the radial side where the LUCL is attached.
Yeah.
Two things. We got a few questions. Dave, I don't know if you want to.
Yeah. So a couple, what are your go-to graft struts to maintain width when you have significant central articular bone loss as in an open fracture? I generally don't graft in the articular region. You know, like I think I showed in that one open case, when you have a piece of articular cartilage that's gone, it's just gone. The good thing is that we don't walk on our hands. So, you know, you're not going to load it the same. And it's really more so about obtaining a functional range of motion, which you can still obtain if you heal with fibrocartilage at the joint.
And I've used montage occasionally, just as, you know, to fill that spot, just knowing that at some point it may absorb, it may not. And then if it's a really big articular segment that's gone, I will use, I will use PMMA with a plan for coming back for a allograft. But that's kind of the only thing you have if it's a really big articular piece that's gone. And then
Yeah.
like Dave, for that metadiaphyseal bone loss, I've used, the same thing, just bone graft, allograft, but oftentimes it's a plan to come back and do it.
Yeah, I
And
think
then
one of
so
the keys to bone grafting is not reducing the space. You have to maintain the space. If you
Mhm.
can fill it with bits of bone that aren't necessary from other regions to fill it, and not the articular surface, but the interposition, so you maintain the width under interference, that's always very helpful, whether it's with bone that's around or with bone substitutes. And later coming in, but really we're keeping that restoration of the length and the distance, the width is really key.
I was just typing out an answer, but question about thoughts on bioabsorbable pins as opposed to lost K-wires. I'll use those occasionally. I think that that's totally fine as well. When I do use a small K-wire that I intend to leave, I'll make sure that it is threaded so it won't migrate. So once I get bite in the subchondral region, I'll leave it there. If I'm happy with it, then I'll just snip it. But you certainly can use bioabsorbable pins.
Yeah, my
Let's see.
go-to is a fully threaded K-wires. I just stack them, and the small ones work really, really well. It's amazing how much fixation you can get from a tiny fully threaded K-wire.
Yeah. Another common question for you. Do any of you use routine HO prophylaxis for some of these distal humeri? Milton, are you using anything?
No, not usually. I mean, it really depends on the injury. The problem is, someone mentioned this kind of in our symposium at OTA, right? The people who you'd want to use HO prophylaxis for, like big bad injuries, people with head injuries, those are the people who are at highest risk for developing ulcers and ending up with gastritis. So you kind of want to avoid things like indomethacin for them. I haven't used radiation acutely for any of these patients, but rarely indomethacin for some patients who I may be highly concerned who don't have any other thing that could increase their risk of gastritis.
Yeah, I don't routinely use HO prophylaxis as well. I deal with it as it comes. If the patient needs an arthroscopic capsular release, or if they need an osteoplasty, then I'll deal with that kind of PRN. Let's see, I think we have time maybe for one or two more. Let's see, Diane, you're answering one. How do you consider associated coronoid fractures in terms of approach and fixation? D, when you're dealing with some periarticular stuff, if you have a concomitant, proximal ulna, proximal forearm injury with a coronoid element to it, does that change your approach fixation?
No, I think the nice thing about a universal approach when you're doing a distal humerus is that you can make a submuscular approach medially. Remember, the coronoid is predominantly a medial structure. So you can actually crawl right up on that coronoid, especially for tip or even anteromedial facet impaction. Now, that combination of injuries with the distal humerus is rare. But if you get normally you'll get a larger coronoid fragment. And so it's best to go on the medial thigh, but know that you're not very far from it. So if you just stay on the subcutaneous border and move anteriorly, you'll come right across onto the coronoid and you can see it.
The other thing is you can work through the fracture and just drop your columns out. If you can get your appropriate visualization, you can actually see it from like through your fracture.
Awesome. So I think we were right on time. So all good questions. So in conclusion, I think you guys can see every distal humerus fracture doesn't necessarily need an osteotomy, and you should familiarize yourself and become facile with triceps-sparing techniques. Be on the lookout for some of the harbingers of making it a more challenging case. Those being some of the anterior impaction and comminution, certainly about the trochlea, and some of the more coronal oblique elements as well. At the end of the day, remember your basic principles. It's a joint. It needs to be anatomically reduced with absolute stability, and that's an absolute must. And at the end of the day, also, if everything fails and you're just struggling, you're trying a trap approach, you're trying to do a columnar approach, and it's not your day, you got to grab the microsagittal saw, do your osteotomy, and see everything. All right. So with that, I would encourage you all to continue to participate in the AO Fellows webinar series. Some of the upcoming ones, posterior fracture dislocations about the pelvis with Jason Nascone from Baltimore. And on November the 8th, that's a Wednesday, John Scalero from LA is going to be moderating the distal femur fracture management, 1-2 plates versus nail plate. All right. So with that, I'd like to thank Diane and Milton for taking time out of your Tuesday evening to sit with me. And to all of you who took the time to participate, I hope that you found it educational. We look forward to seeing you on a further webinar. Have a good night, everyone.